Good afternoon and welcome to our Cardiac and Vascular Lecture Series. During this interactive presentation, you will have the ability to ask questions via the Q&A icon on your screen. Please post your questions directly to the moderator. This afternoon, I have the distinct pleasure of introducing Dr. Eli Friedman, who will be presenting on topics of cardiovascular care of athletes. Dr. Friedman is a medical and sports cardiologist at the Miami Cardiac and Vascular Institute, which is part of Baptist Health, South Florida, and serves as the Institute's medical director of sports cardiology. Dr. Friedman earned his medical degree from the Chicago Medical School at Rosalinda Franklin University, North Chicago, Illinois. He completed his internal medicine residency and cardiovascular disease fellowship at the University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania. Prior to joining Miami Cardiac and Vascular Institute, Dr. Friedman served as the Chief of Cardiac Services at Memorial Regional Hospital and the system's Medical Director of Sports Cardiology. Dr. Friedman is a team cardiologist for the Inter-Miami Soccer and for numerous local universities and colleges. He's a member of the USTA Sports Science Committee and serves as the advisory sports cardiologist for the Broward County Public Schools Sports Medicine and Student Wellness Committee. Since 2018, he has helped develop the Heart of Champions program through a partnership with the One Beat CPR, cardiopulmonary resuscitation, and the AED, automated external defibrillator, and the American Heart Association. This program teaches trainees, including coaches, student athletes, and athletes administrators, how to recognize and respond to cardiac arrests in sports settings. His research has been published in journals of emergency medicine, services, and congestive heart failure. He has also co-authored educational centers in American College of Cardiology. In addition to English, Dr. Friedman speaks Hebrew and is familiar with Spanish. Please let's give a warm welcome to Dr. Eli Friedman. Thank you so much for joining us, Dr. Friedman.
Dr. Hakeem, thank you so much. It's really a privilege to be here and really looking forward to talking about the thing that I'm most passionate about, which is sports cardiology and the care of athletes. Just going to set everything up here and share the screen. So as Dr. Hakeem said, I have the distinct privilege and honor of leading the sports cardiology program here. And it really takes a village to care for athletes. And I hope to shed some light on that for you today. It's important to know some of the disclosures that I have, the organizations that I worked with, as Dr. Hakeem outlined. These are the goals for today's talk. The disclaimer for the goals is that each one of these could probably be a 45-minute talk in and of their own right. So we will do our best to sort of give you the bird's eye view on all of this. I certainly look forward to the Q&A at the end of the discussion, and please feel free to ask any question. This is a complicated topic with a lot of nuance, so please, ask any questions. But what I hope to do first is just tell a story and give you the story of exactly what sports cardiology is, and that includes exercise-induced cardiac remodeling, how we screen our athletes, how we evaluate our symptomatic athletes, and then talk about athletes with established cardiovascular disease who still want to compete and train at high levels. A question we get asked often, and I think that exists in the lay public, is there such a thing as too much exercise? And I'll touch on that. Well, we're now in 2021, but still the spillover of 2020. You can't have a sports cardiology discussion without discussing COVID. And then emergency action planning, which Dr. Hakeem highlighted, is really my passion non-clinically. And I do want to shed some light on my thoughts and goals there. So what exactly is sports cardiology? What it is the dedicated cardiac care of amateur, professional, or highly athletic, highly competitive individuals. It is a growing population, largely driven by people's awareness that sport and exercise has significant and tangible health benefits. We have more and more people exercising, and this starts in the early teens and hopefully even earlier than that. And we have those in their 70s, 80s, even older, who are exercising and doing so at a competitive level. And athletes just have a different clinical presentation than that of the general population. How we treat athletes is very different, and they're quite different than our usual cardiac patient. And really, a sports cardiologist is being recognized as a necessity at the amateur and professional levels. The teams and organizations are constantly looking to cardiologists who are familiar with athletes to help guide them. If you are familiar with ancient Greek stories, then you'll know who this is. If not, this is Pheidippides. And if you're not familiar with Pheidippides was a messenger during the ancient times. He ran from Marathon, Greece to Athens to deliver the message of the Battle of the Victory at Marathon. And if you know anything about endurance sport, you will know that he ran 26.2 miles, which is the inspiration for the modern day marathon. And if you're familiar with his story, you'll know that once he reached there and delivered his message, he suddenly died. So we call him our first sports cardiology patient at that point in time. If you're into athletics as well, you'll know who this gentleman is. This is Jim Fixx. Jim Fixx was a gentleman who wrote the book called The Complete Book of Running. He had found the religion of sport and of exercise and ran and ran and ran. Lots of people said that it was unhealthy. He said no, it was the healthiest thing that could ever happen to him, until he was found dead on a trail one day. A lot of people blamed his running and his high doses of exercise for the cause of his death. But if you look back at Jim Fixx, he had a significant family history of heart disease. He drank, he smoked, and he was overweight in his 20s and 30s, and then found the religion of running. So others would argue that the running kept him alive longer than he would have lived otherwise. So that provides sort of a basis of the history of sport, and obviously there's lots of different stories and anecdotes in between there. This is from the Journal of American College of Cardiology. Aaron Baggish, who leads the cardiac performance program up at Mass General, published sort of a core curriculum for sports cardiology. And he outlined sort of what would be 4 pillars, and you can see those here. EICR is exercise-induced cardiac remodeling. That is the athletic adaptation to exercise. I'll describe that to you momentarily. We talk about the evaluation of symptomatic, highly active individuals, the management of athletic individuals with cardiac disease, and then pre-participation screening. These are really the core fundamentals, the pillars of sports cardiology. So when we get into exercise-induced cardiac remodeling, the most important thing I do and we do in our clinic when we meet an athlete is find out exactly what sport that athlete participates in, what kind of training has he or she done, how long have they been doing it for. And that's exquisitely important because different sports will change how the heart adapts. The heart is a muscle like any other muscle in the body, and the sport or the training in which you expose it to will change how the heart looks on testing, how it even looks grossly if you were to look at the heart. And so when we think of athletes, we think of dynamic or aerobic components of exercise, or we think of static or isometric component of exercise. So if you think of those who are purely dynamic, purely aerobic, it tends to be those who are long distance runners, field hockey, race walking, et cetera. There's really not a lot of resistance there. Versus on the other side, on the y-axis here, those who primarily engage in isometric or static exercise are those who do gymnastics, martial arts, perhaps water skiing, weightlifting, really not much of an aerobic component to those exercises. Or if you combine both of them and you get into high aerobic and high dynamic components of exercise, canoeing, kayaking, decathlon, speed skating, triathlons, now you're combining sort of the musculoskeletal and the cardiopulmonary systems into one. So we spend, again, a significant amount of time with our athletes, getting to know them, asking them the questions, how long have you trained for? How long have you done this? Because then it goes into incorporating it not only into their treatment plan, but also their diagnostic plan, trying to figure out exactly what brought them there and how their heart should look. And when you expose the heart to those trainings, this is how the heart will sort of change. So if you take a normal sort of pre-trained heart on the top and you expose it purely to endurance or aerobic training, what you will see is that the left ventricle can actually enlarge in size and that the walls of the left ventricle can thicken somewhat, something called eccentric cardiac remodeling. And the right ventricle can see some of that as well. There can be dilation of the right ventricle, as well as the receiving chambers, the atria of the heart. If you think of this in purely physiologic terms, this is increased cardiac output. That, a resting cardiac output, 6 liters per minute, 7 liters per minute, can go above 30, if not more, in really highly trained aerobic athletes. In the cardiovascular system, the heart will change in adaptation to that. One key feature to note is that the RV, the right ventricle, should not dilate in absence of left ventricular dilation. If both chambers are enlarged, great. But if only the right ventricle is enlarged, that can be pathology, and that needs to be carefully considered. Versus on the right side of the screen, someone who engages in purely strength training exercise, really not going to see much in the way of right ventricular change. But the left ventricle, the walls can thicken, and the chamber really shouldn't enlarge very much. And the reason behind that is that in strength training, what you're really doing there is you're increasing your afterload. So you're increasing blood pressure, you're increasing the force that the left ventricle has to generate in order to provide and move blood forward. So if you take a power lifter, let's say they're going to squat 700 pounds, they're going to bench press 500 pounds, systemic blood pressures can go above 300 millimeters of mercury. And certainly the heart has to generate a force, the left ventricle must generate a force greater than that. So very, again, key components to understand with what our athletes are doing and how the heart should change in adaptation to that. So when we take that as our basis, when an athlete enters into our clinic, let's say purely for screening purposes, how do we evaluate an athlete? Well, traditionally, this is done with a pre-participation exam. This is done with a history, spending a lot of time talking to the athlete, making sure there are no symptoms or evaluating symptoms they may have, and then doing a physical exam. And it tends to be a comprehensive physical exam, as I'll show you. Occasionally, an electrocardiogram or an ECG will be added in, and then we can do other testing as well with an echocardiogram, and I'll touch on sort of the nuance of that momentarily. However, in this country, in the United States of America, what is recommended is called the AHA, American Heart Association 14-point screen, which I've outlined here for you. This, or what's called the PPE4, pre-participation exam 4, are the only mandates that we have in this country for a pre-participation exam. There's no mandate for an ECG, there's no mandate for an echo, and oftentimes it's recommended against, and I'll discuss with you why that is. But if an athlete ends up in your clinic, what you're going through are these 14 elements. You want to know, is there any chest pain, discomfort, or tightness with or related to exertion? Is there unexplained passing out or syncope? What we call disproportionate or inappropriate shortness of breath or fatigue with exercise? Is the athlete putting in much more effort than he or she would expect than for the activity they're doing? Has there ever been recognition of a heart murmur, elevated blood pressures? Has the athlete ever been restricted from sport? And has there ever been any cardiovascular testing? That's just in the history alone. Perhaps what differentiates us from regular cardiologists is we spend a significant amount of time in the family history. We want to know any type of cardiac conditions that run in the family. We ask often, has anybody died suddenly at a young age? Has anybody drowned? Has there been unexplained motor vehicle accidents? Anybody with a defibrillator or a pacemaker or any of these conditions? And oftentimes people in general, but athletes as well, will say so-and-so had a heart attack when they were 35. And as you may know, that word heart attack is very loaded. You know, when that is told to us, we want to know whether or not an autopsy was done. Was there truly a myocardial infarction with cessation of blood flow to the heart because of an obstructive coronary lesion, or did something else happen? Because as you can imagine, the implications are significantly different for premature coronary artery disease causing a myocardial infarction and sudden death versus sudden cardiac arrest from innumerable other causes, such as a pulmonary embolus, a cerebral aneurysm. The details really do matter when you're screening an athlete. And when we do a physical exam, we listen very closely, as you can imagine, for a heart murmur. We feel the femoral pulses to see if there's any delay, a radiofemoral delay, to rule out aortic corrication. We certainly look for Marfan syndrome, and then blood pressure is exquisitely important as well. So I mentioned I was going to touch about ECG screening in athletes. Very controversial. Again, in this country, no blanket recommendations for ECG screening. In fact, it's discouraged. But if you go overseas to our counterparts in Europe or in Israel, for example, there are mandates for ECG screening, and the International Olympic Committee mandates ECG screening. A writing committee got together in 2016, 2017, and put forward these sort of criteria for what's normal or abnormal in an athlete. If you fall into the category on the left, all of these green findings, you can have as many of those as you like, you're normal. You require no further evaluation, again, as long as this is in a screening setting with no other type of physical exam stigmata or complaints. In the middle, there are borderline criteria. You're only allowed one of those. If you get two, you do require further evaluation. And then certainly you have all of these abnormal criteria here. The ECG screening of an athlete is incredibly different than what's normal for that of a general cardiology patient. So there's this black athlete pattern that's noted here, described best in London by Sanjay Sharma. You can actually have T-wave inversions in V1 through V4, something we wouldn't consider normal in a general population, but in our young African-American athletes or those of African ancestry, that is normal. Mobitz type 1, Mobitz 2, Mobitz 1, second degree Mobitz 1, that type of heart block, totally normal for an athlete. So lots of things here that is very different again for the population. And we see quite often where an ECG is done in an athlete and it's termed abnormal, but actually, in fact, it's a normal pattern for the athlete. So very important to know. Echocardiography is usually not recommended for screening purposes. With many of the colleges that we cover and the professional organizations that we cover as well, echocardiography is mandated, different states, different things on the line, way more sort of publicity. So the echocardiography is used and it's done in multiple different settings. Cardiac MRI has really seen a lot of press these days with COVID. It's really important to note that there is no guideline or recommendation whatsoever for use of cardiac MRI on screening purposes. Cardiac MRI is a diagnostic tool used when somebody's met criteria for certain advanced imaging, but it should not be used for screening purposes. So as we transition into actually caring for these folks, other than screening, those coming with symptoms and established disease, I want to give you a case, and all of these are real cases. So we recently saw a 54-year-old longtime runner with palpitations, skipping heartbeats. He'd been running 25 to 30 miles per week, doing that consistently for 20 years. His volume of exercise included marathons and half marathons, really no previous medical history, and like a lot of our athletes, does not seek out routine medical care. This was his ECG, and as you may be able to appreciate here, he had 3 PVCs. If you go back to our ECG algorithm, you're allowed no more than 1 PVC as an athlete on a screening ECG. This athlete in particular wouldn't fall into that category because those criteria are only for those under the age of 35. But again, 3 PVCs in a marathon runner with palpitations does raise some concerns. So how do we evaluate our symptomatic athletes? Well, it's really complex and it's very detail oriented. Oftentimes we spend an hour or more with these athletes getting to know them on significantly detailed levels so we can understand how things happen. Certainly we do a history of the present illness. We delve into the condition, we do a review of systems. But as I've sort of alluded to at this point, we get very detailed athletic histories. We spend a lot of time talking about nutrition. We talk about sleep as well. Really all important things that go into the performance of an athlete. Medications, obviously, we're asking all of our patients about medications, but things that perhaps we don't ask as much in the general cardiac world, but that's important in the athletic world, are supplements, vitamins and minerals, performance enhancing drugs, how much caffeine or alcohol is the athlete using? Are they using any other type of substance that could play a role in the symptoms they're coming with? And as I've told you, family history is very important as well. We have lots of tools in our arsenal and a strong group of a multidisciplinary team in our armamentarium. So certainly ECG and echo, as I've talked about. Coronary CTA is a huge tool that we use, especially when we're looking for anomalous coronary arteries in our younger athletic population. Cardiac MRI, which you see an image on the right, gives us tons of diagnostic data and therapeutic data as well in certain instances to help our athletes and keep them as safe as possible. And then we do a lot of stress testing. One we do that's a little bit different than, again, a typical cardiac evaluation is cardiopulmonary exercise testing. So you see an athlete here. This is a representation of a test that we do. The athlete puts on the mask, has ECG and blood pressure monitoring, can get on a bike or a treadmill, and we do maximal testing. So typically you'll hear of patients going and getting a stress test, reaching 85% of their maximal predicted heart rate, getting the injection of the nuclear isotope, or just completing the ECG stress test and being done. In our clinic and in our testing, we push these athletes to the max, to the point where they're saying, Eli, get me off the treadmill, Eli, get me off the bike, stop. Because these athletes push themselves to extremes, and we need to know how their cardiovascular systems react to that. So the cardiopulmonary test is able to evaluate the interaction between the cardiovascular, the pulmonary, and the musculoskeletal systems in response to exercise. It's really important that we try to exercise the athlete in the sport that he or she does. So we would never put a cyclist on a treadmill, and vice versa. We would never put a runner on a cycle. We really try to get the athlete engaged in the sport that he or she does. You may have heard this test called a VO2 max test before, so we're able to measure the fitness of the athlete. We're able to obtain the anaerobic threshold of the athlete when the athlete crosses over from purely aerobic metabolism to anaerobic metabolism. We're able to see if there are any limitations to cardiac output in terms of exercise. It's really an invaluable tool, and we do it quite often in a lot of our athletes. They enjoy it because they get lots of data, and I love it because I get lots of actionable data that I can use not only as a baseline, but I can use as a therapeutic mechanism as well as we get our athletes back from symptomatic disease. So again, it can also help us to differentiate adaptation from pathology. And as a cardiologist, I do think often about things like exercise-induced bronchoconstriction and exercise-induced laryngeal obstruction. So exercise-induced bronchoconstriction, otherwise known as exercise-induced asthma. We will routinely do exercise-induced pulmonary function testing and see if there is asthma at the end of it. And then exercise-induced laryngeal obstruction is probably underdiagnosed if you read from the sports pulmonologists out there. This is otherwise called vocal cord dysfunction. It requires multidisciplinary work, exercise-induced pulmonary PFTs after the exercise. And occasionally we've even done nasopharyngeal laryngoscopy with exercise to see how the vocal cords adapt with exercise. So I don't treat those conditions, but I certainly can work to diagnose them. And again, these are highly underdiagnosed in our athletes and things we look for and things that we think about. So here's another case for you. A 62-year-old master cyclist who had an inferior wall myocardial infarction at a hospital system that wasn't ours. He received a stent to the obtuse marginal artery with reported 70% blockage in the mid to distal right coronary artery. His ejection fraction was 43% on echocardiogram at that time, with regional wall motion abnormalities. He was placed on very appropriate medical therapy, treated very well by the cardiologists who saw him. But like most of our athletes, after, as soon as the catheterization was done, as soon as the stent was in, he began asking questions of how soon can I get back on the bike? How soon can I train? How soon can I compete? So these are always much better in person, but we are where we are. So I want you to think about, what would you recommend? Would you tell the athlete as he's sitting in bed that he can start back now and requires no further testing? Would you say his career as a master cyclist is done? Or would you say he needs multimodality cardiac testing with shared decision-making? So hopefully, I see Dr. Hakim smiling here, but yeah, the answer would certainly be the third one. We really look for reasons to keep our athletes exercising and engaged, and shared decision-making is very important. Medicine used to be very paternalistic. Do what I say, and that was sort of it. Now we really engage our athletes and our patients in general and have discussions with them about their risk, what their goals are, and try to come to a treatment plan. So this illustrates athletes with established cardiovascular disease. And as I told you at the beginning, we have more and more people coming to exercise all the time because of the benefits from a health perspective. But people are really doing this competitively. The number of collegiate student athletes in our country is increasing. We have people doing ultra marathons, triathlons at records never seen before. So we have people not only doing this for health, but we have people doing it competitively. And as I told you, we see people doing this at quite an older age, including this gentleman here who began running much later in life, in his 60s, started doing marathons, and in his 9th and 10th decades of life, believe it or not, continues to do so. So, when we talk about our athletes with cardiovascular disease, we need to give careful consideration when we talk about that shared decision-making. First, we want to know what the diagnosis is. There's something very different about obstructive coronary artery disease and ischemic cardiomyopathy versus an athlete who has atrial fibrillation. Are there any high-risk features? So high-risk features would be a depressed ejection fraction, lots of ventricular ectopy, residual obstructive coronary artery disease that wasn't treated. Do they have an arrhythmogenic protoplasm? In other words, is there scar in their heart that could potentially cause ventricular arrhythmias? Have we exercised them? Have we put them on a bike or on a treadmill and seen what happens? And I mentioned here, be careful with coronary artery blockage percentage. So as I gave you in the case before, there was still residual disease in that previous athlete. You would think that the people who die in marathons have obstructive coronary disease, myocardial infarctions. But if you look at data that came out in about 2012, in fact, it tends to be supply-demand mismatch that can cause these sort of heart attacks at the end of races, meaning there isn't acute plaque rupture and cessation of blood flow into the arteries. It's those 40, 50, 60, 70% blockages that maybe we wouldn't put a stent in that can still cause issues. So again, very careful thought process and a lot of multidisciplinary care with our interventional colleagues when it comes to athletes with quote unquote non-obstructive disease. Medications that we prescribe to our athletes can definitely impact performance negatively. So beta blockers, if you give beta blockers to an athlete routinely, they're going to call you within 2 days complaining, not only because they decrease heart rate in people who may have already bradycardic heart rates, but because if you talk to athletes, they describe it as just a fog being put on their body, cobwebs. They can't perform the way they want to. They can't get their heart rates up. They can't achieve their athletic goals in the same way. So these are very these are medications we are very careful with and only prescribe when truly indicated, and do so with lots of discussion. And the same is true with our non-dihydropyramine calcium channel blockers. Diltiazem and verapamil can do the same thing. You have to be careful with athletes in terms of medications that can be on watch lists as well. So diuretics are notoriously tested for. They are on the USADA list of you cannot use. And then believe it or not, ACE inhibitors and ARBs are on the watch list as well. So we have to be very careful with the athletes we're prescribing things to. And again, need to have those discussions and even fill out waivers at times so they can continue to take them. And as I alluded to, cardiopulmonary testing is extremely helpful in our athletes. Again, establishing baselines, understanding where they're at with established cardiovascular disease, which then can help us should the athlete develop symptoms to see if there's been any changes. So this is a question that we get all the time. You know, is there such a thing as too much exercise? The people will come in because their family members have told them you're exercising too much, you're going to have a heart attack, you're going to kill yourself. And the other question is to someone who achieves high levels and high intensity of exercise, am I putting myself at risk? My heart rate getting up to these high beats per minute, am I going to have a heart attack? Is something really bad going to happen? And this is fueled a lot by the lay press. There's articles written about this all the time. This is one of my favorite ones, Cycling to Extremes, Heart Health and Endurance Sports. There were lots of quotes in this arguing on both sides. It was a very well-balanced piece. This is from the Velo cycling paper. I think this came out in the early 2010s, so you could certainly look this up and read about it. But you see, I mean, this is a cyclist. They show his heart and cycling to extreme. Just love the captions there. And then heart attacks at the mega fit. How safe is extreme sport? This was out of Australia in 2018. Their leading endurance athlete, who was 47, Dean Mercer, was found on the side of the road in his car, who had passed away. And my favorite quote from inside that article was this: I probably feel that one of the reasons for this, and it hasn't been absolutely proven, but it's quite logical, is that if you push yourself too hard, you're overstretching all of the mechanisms in the body, Walker said, including the heart. Like anything that's overworked, it eventually gives up. This was from the Australian cardiologist. And let me tell you, let me show you this, and then I'll tell you how this all sort of comes together. So the current thought process is that on the left, that the health risk is high in terms of on the y-axis, health risk. The health risk is high with no exercise. I think we can all agree that those who don't exercise, their blood sugars go up, their blood pressures go up, their blood glucoses go up. But as we begin to exercise, there is a health benefit to that. So more exercise, and you can see the benefits are better for those who go from doing nothing to something, and that eventually it levels out. So somebody who's doing an ultra marathon once per week is not tangibly going to be healthier than someone who engages in the recommended dose of exercise. But what that cardiologist is alluding to before is that could this actually be a J-shaped hypothesis, where that by achieving a higher dose of exercise, are you actually putting yourself at risk? Are there actually going to be a net health loss in terms of all of this? So let me tell you, before I get into some data on other issues, that there is no evidence to suggest that extreme exercise impacts health in a negative fashion, that it will lessen your life, lessen your quality of life, or cause more heart attacks, et cetera. There is absolutely no data to support that. So that quote from before just isn't logical. To take it a step further, gold medal Olympic athletes live longer than the rest of the population. To take it a step further than that, gold medal aerobic trained Olympic athletes live longer than strength-based Olympic athletes. So those who are engaging in extreme aerobic exercise, which is what that article is referring to, live longer and live better than the rest of the population. Now, you could argue with me and say, Eli, these are, Darwinism, the fittest of the fit, naturally selected creatures. And I would agree with you on that. But still, again, no evidence to suggest that high intensities and high volumes of exercise per week in anybody causes worse health outcomes. And that's illustrated here. With anybody, anytime they exercise, there is a risk of having a myocardial infarction. That is true across the board. But it's most true in sedentary subjects, that the relative risk can go up significantly in those who don't exercise, who decide to engage in exercise. As we exercise more, that risk of having an adverse event goes down. So it can happen in anybody, but it's way less likely in those who are habitually exercising. But to be fair, and to present this all with equipoise, there are two conditions that we can associate with increased doses of exercise. One of those is atrial fibrillation. If you're not familiar with atrial fibrillation is the most common irregular heart rhythm worldwide. And believe it or not, it is more common in our aerobically trained male athletes who've been doing this for years and years at high volume than that from the sedentary population. So if you take a look at these curves here, the red curve is a man who engages in exercise. If he's sedentary, he has a certain risk of atrial fibrillation. As he reaches a moderate dose of exercise, he's actually protected. But as he engages in high volume, high intensity aerobic exercise for years, his risk of atrial fibrillation goes up. And that same thing is illustrated here on the solid line, that there's a protective benefit, but then it does become a higher risk of atrial fibrillation as we move forward. Women are protected all the way throughout. The more exercise a woman does, the less chance of having atrial fibrillation. And the mechanisms for this are illustrated here. We have proven mechanisms like atrial fibrosis, the inflammation that comes with high doses of activity, the exercise-induced cardiac remodeling or atrial enlargement, and an increased vagal tone that comes from exercise. We think the sympathetic stimulation when we exercise at aerobic levels may cause this, and then pulmonary vein triggers. And then we wonder whether or not there's genetic susceptibility. It's really important to note, I would never discourage anybody from high volume endurance exercise because of the risk for atrial fibrillation. So I know those of us who do this, we wake up and check our pulses every morning. We know it's going to potentially come at some point in time, but it is not a reason to engage in high volume aerobic exercise. The other issue we see in once again, men who engage in high volume aerobic exercise is that of coronary artery disease, or probably better stated, coronary artery calcification. Again, this is from Sanjay Sharma. This was in Circulation. So male controls, those who are not high volume aerobic athletes, have a certain degree of coronary calcium. But men who engage, again, in high volume aerobic activity actually have way more coronary calcium than their sedentary counterparts. Very interesting data. And if you look at it, you can actually see that it's real. You get it in the LAD, you get it in the coronary arteries throughout. So you see more coronary artery calcium. And the reason behind this isn't exactly clear. It hasn't been proven yet. Postulated mechanisms include an increase in parathyroid hormone during exercise, an increase of flow into the coronary arteries during aerobic exercise, and then sympathetic stimulation. We think all of that may cause the increased burden of coronary calcium. It's important to note, though, that the data that's coming out on this, it does not lead to a higher risk of heart attack. It does not lead to an increased risk of morbidity or mortality. That this happens, we see it, and we just sort of treat it and deal with it as we would anyone else, but it doesn't have bad outcomes in the end. You may have heard of coronary calcium scores as a means of screening for coronary artery disease and decision-making on statins. I will never use that in our high-volume male endurance athletes because of this reason exactly. So atrial fibrillation, coronary artery calcium, those are the two things we can say with relative certainty are the only risks that come from high-volume endurance exercise in the general population. Transitioning again to this guy, COVID, we've all seen this, we've all been encumbered by it. I hope personally none of you have been affected by it. The disease is real and it happens, and it certainly has affected our athletes. But I think it's important to go back to basics to understand how we got to where we are and why the cardiovascular system, and especially the cardiovascular system of athletes, took on a lot of headlines in the midst of all of this. So COVID-19 is the disease. The virus is SARS-CoV-2. It gains entry into our system via the ACE2 receptor. The ACE2 receptor is found in the lungs, it's found in the heart, it's found in the vasculature. And by gaining entry, it can cause acute lung injury, adverse myocardial remodeling, vasoconstriction, vascular permeability. And what we've seen that it can do on the heart is, number one, cause inflammation with indirect damage. This is the body's immune system reacting against the virus and the heart being an innocent bystander. But we've also seen where the virus can gain direct infection into the myocardial cells via those ACE2 receptors. Troponin has gained a lot of notoriety through all of this, and testing our patients in the hospital with the viral illness to look for myocardial damage. But it's important to note that in athletes, troponin can be elevated just by participating in sport. Running on a treadmill at a high intensity, even for 30 minutes, can cause troponin elevation. And this was looked at out of Boston, at the end of the Boston Marathon, that troponin increases at the end of a marathon. So those are sort of the basics to understand as we get into our athletes. And how did we arrive here? So March 11th, 2020, perhaps you don't remember it, but in America, this is the day that this happened. So Mark Cuban checking presumably his Twitter or social media feed. We were all at home hearing about COVID. The cases had been identified in America. But this is the day that an NBA player tested positive for COVID. The NBA immediately suspended their season. Sort of in this country, this was the first domino to fall. We all of a sudden said, oh my goodness, it's here. And our world stopped, the sporting world stopped. And everybody began to say, oh my goodness. And so at that point in time, sports cardiologists sort of got together and said, oh my God, because what we were learning about with COVID-19 patients was that the hospitalized ones really were having a lot of evidence of cardiac disease. But we really knew nothing about the healthy young athletes in the disease. But we were really scared that asymptomatic or mildly symptomatic athletes with COVID could be having issues like we saw in the hospital. And most concern was that for myocarditis. So we began thinking about athletes this way, and we divide them into categories. We think of athletes who have mild symptoms, which is really any symptom above the chest or GI symptoms, no fevers. Those with moderate symptoms, so any of the mild symptoms plus fever, shortness of breath, chest pain, or severe fatigue. And then those with severe symptoms, any of the above, but requiring hospitalization. So we broke our athletes down into categories, and led by a group of colleagues from around the country, an algorithm was put out. And it basically stated, if you look at this, this is from May 13th, 2020, that any athlete who had mild or asymptomatic really should be thought of for cardiovascular risk stratification prior to returning to sport. And when we say risk stratification, that meant an ECG, a troponin, and an echocardiogram. And if all of those were normal, then the athlete could get back into sport. If they were abnormal, then further care would be needed. This has changed, but this was happening professional level, college level, and it was even recommended to be considered for high school athletes. The media really caught on to all of this. There were lots of studies put out based on MRI data in otherwise asymptomatic athletes. There was MRI data coming out saying that there was myocardial inflammation in every single COVID athlete out there. And so the major news organizations, ESPN, Sports Illustrated, Yahoo, really all painted this as a story as these sporting leagues shut down, saying that it was a heart concern that was causing it. And this is evidence of one of the studies. This is one of the newer ones, which fortunately has reassured us. You can see the date, January 14th, 2021, but it's evaluation for myocarditis in athletes recovering from COVID. And pretty much every athlete was getting that troponin, getting the ECG, the echo, but they were all getting MRIs. And in that study in particular, there was a very low burden of myocarditis, something on the order of 1%. But those of us who were doing this, personally having seen hundreds of athletes now with COVID and those around the country, what we have found is that those with mild symptoms or no symptoms at all really are not having the myocarditis, really are not having any cardiac involvement of the athlete. So the group got together again, and now this was from October of 2020. We changed the guidelines, and they're to be applauded for doing this. Now those with asymptomatic disease or mildly symptomatic no longer require cardiac risk stratification. And that's been very appropriate. I can tell you personally, I think we have fortunately overestimated the cardiac effects of COVID. And I think we've underestimated the asymptomatic or the unrecognized pulmonary effects of it in our athletes. I think there may be atypical viral pneumonias that we're missing because our athletes are otherwise healthy. And we care about all of this. We're going through all of these protocols and all these screening algorithms because of myocarditis, as I mentioned. Myocarditis is known to be a cause of sudden cardiac death in athletes. It's inflammation or infection of the heart. If an athlete is diagnosed with myocarditis, or anyone for that matter, really we put them on the bench with no activity for 3 to 6 months. In order to get them back into sport, we then need an ECG, an echocardiogram, a Holter monitor, blood markers, a cardiac MRI, and then we'll do that maximum cardiopulmonary exercise test to ensure that they're safe to get back in. So the implications of diagnosing myocarditis are really significant. And if you go back and look at all those studies, these MRIs were done without further criteria to lead to an MRI. So an MRI to be done for myocarditis, you need to have symptoms. Your pre-test probability needs to be high. I really encourage you to go back to that article from JAMA just last month. And Jonathan Kim wrote a really fabulous editorial talking about cardiac MRIs in myocarditis. Really, the MRI should not be done unless there is suspicion of myocarditis. So a diagnosis of myocarditis is significant, and it requires a lot of thought and testing to get back. The silver lining from COVID, from the sports cardiology perspective, is that we've known for a while that it really takes a team to take care of athletes. That's true of the primary care sports medicine physician, the orthopedic sports medicine physician, the athletic trainer, the parents, the family, and cardiologists have been a part of this. So we really have developed really good teamwork with all of our partners in this. And it's been the silver lining that we've all worked together to keep our athletes as healthy and as safe as possible. Why we care about all of this, though, is because we're trying to prevent sudden cardiac death. That is what we want more than anything else. And this paragraph here sums it up more than anything else. And that ECGs, echoes, MRIs, they're all really great. And we can debate till the cows come home about which is most effective. But what there's no debate about is that a well-rehearsed and effectively implemented emergency action plan, or EAP, for the treatment of cardiac arrest is effective at reducing the risk of death. If you can recognize cardiac arrest, if you can respond to it and treat it appropriately, you will save lives, and that's undoubtable. So as Dr. Hakim mentioned, I've been passionate non-clinically about making sure everybody has access to CPR training, to AED usage. We are passionate about that on multiple levels. So we've trained a local college here, their student athletes. This was all prior to COVID. We've trained their coaches, their athletic administrators, their student athletes, because we view them all as responders. The program initiated because the institution that I was at prior provided medical care for a local underserved university. And when we met with them, we found out that none of their coaches were trained in CPR, and none of their administrators were trained in CPR. There was one AED on campus, and it was all the way on the other side of the campus, nowhere near their athletic facilities. So we taught them all, we donated an AED. If you look at data in America, from 2017, only 50% of youth coaches are trained in CPR and AED usage. That means if I send one of my children to a youth sports league, it's a flip of a coin whether or not that coach is going to understand CPR, AED, and how to recognize cardiac arrest in a sports setting. Totally unacceptable, in my opinion, and we are actively working to change that, and certainly want to partner with anybody else who may be passionate about this to ensure that CPR can be used and hopefully not used, but taught and empowered with. So again, this just sort of summarizes that, is that an emergency action plan is really the most important thing that any athletic organization can do. Understanding what the risk of sudden death is. Is there a regional referral center where partnerships can be had in order to keep athletes safe? Working with the local organizations, police, EMS, fire, hospitals, making sure they're ready to receive an athlete who could have a problem. And again, probably the most important, training all of the stakeholders in CPR and AED usage. So what I hope you take home from this, the cardiac care of an athlete is really detailed, it's really nuanced, it requires a lot of thought, a lot of time, and really getting to know our athletes and our referring physicians well, because it really is a partnership. We communicate all the time with all parties. Screening is really a challenge and should be thought of and not just jumped into, but really met about and thought about in terms of the risks and benefits. It's not a one-size-fits-all approach. What we do for Inter-Miami and our professional teams should not necessarily be done for middle schools and high schools and school-aged athletes. There's really no evidence to suggest that extreme exercise is unsafe, meaning that people could die from it, but certainly there are conditions that come along with it, as we highlighted. COVID has changed the game, but I think fortunately we're learning to sort of pull back from where we initially were and are treating it differently. And then always my big take-home message is know how to perform CPR, know how to recognize cardiac arrest, and knows how to use an AED. So again, I want to thank our international department. I want to thank Dr. Hakim and his team and all of you for having me. It was really a lot of fun, and I look forward to taking any questions. Thank you so much.
Thank you so very much, Dr. Friedman. We feel already safer having you in our hospital system, so we are thrilled. And thank you for that incredible presentation. I know that we're going to have a great discussion. You mentioned something so important that we oftentimes hear, and nowadays it has become somewhat of a regular thing that occurs. But not long ago, Keontae Johnson collapsed in the court while playing basketball. And obviously there were multiple speculations, but one of which was, well, he is suffering from myocarditis secondary to COVID. And I'm very happy that you at least went through the physiopathology of this, because it is a question that oftentimes comes as a result of our discussions about COVID and the sequelae that COVID might bring in the future. Obviously, it is somewhat of an unknown. There is a lot of speculation at this point, but there is also a lot of studies and a lot of proofs that sequelae may ensue after this particular infection. Aside from the COVID and the myocarditis that he suffered, what would be your immediate reaction, not knowing that the patient had COVID? What would you think of as one of those conditions or pathologies that you know of for athletes to have that will say, you know what, this seems like, or this looked like X?
Yeah, so it's a great question. It's a loaded one. So for those who don't know, Keontae Johnson, a star basketball player at the University of Florida, had apparently what we believe was a sudden cardiac event during competition. Really, not a lot of data has come out. They haven't shared much, which you can argue for or against that, but perhaps to protect his privacy. There's lots of cardiac conditions in a college-age athlete that can cause sudden cardiac arrest. Certainly cardiovascular disease is going to be the leading one there. That could be hypertrophic cardiomyopathy, long QT syndrome, myocarditis. The list goes on of what it could be. I don't know the University of Florida screening protocols. I don't know what they did after he had COVID, which it was reported that he did. But what I do want to reflect back on is sort of the last part of my talk, which is that CPR, AED, emergency action planning. Even with perfect screening, things are still going to happen. Screening is meant to be a tool to try to find pathology, but we don't always find it. Or even somebody's being completely normal in a moment in time can still go on to develop pathology later on. So, screen somebody a week ago, normal, they can still develop myocarditis within that point in time. So, we have to be aware of it. We have to be attuned to it. Again, it's a partnership with our athletes, athletic trainers, sports medicine physicians, referring physicians, that everyone's staying on top of the student athlete or athletes in general, knowing if they're having symptoms. But things will still happen. And being ready, being prepared, prompt recognition of what sudden cardiac arrest looks like in an athlete, prompt initiation of CPR, put an AED on, and then get that athlete the care that they need. Fortunately, he survived. He got excellent care and is doing okay now. So a litany of things which could have caused it. It's unfortunate. It's terrible that it happened, but it's a really happy ending because he survived.
He was very fortunate indeed. There is a question from Gabriela, and it asks, why would beta blockers impact the performance negatively?
Yeah, fantastic question. So beta blockers are negative chronotropic and negative inotropic agents, meaning they slow down the heart rate and they decrease the cardiac output or contractility of the heart. So imagine taking any type of athlete who needs to get his or her heart rate up, who needs to augment his or her cardiac output to compete in sport. If I'm giving them a medication that's going to work against that, that athlete's going to be pretty mad at me pretty quickly. Again, a lot of the times our endurance athletes have resting heart rates in the 40s, even the 30s. If I give them a beta blocker, they're going to be very mad at me because their heart rates are going to go much lower and they're not going to like it. They also won't be able to augment their cardiac output, their heart rates, in order to achieve their goals. So beta blockers are an athlete's worst friend.
There's also different schools of thoughts in regards to cardiac conditioning, especially in athletes, and the numbers always fluctuate. They go from the 150 to whatever beats per minute and in between. So what happens when a person exceeds his heart rate over 200?
The first question I would ask would be, how old is that athlete? Because we can see our high school athletes and middle school athletes get their heart rates over 200 quite often, and that's totally normal. So that wouldn't bother me. If the athlete is not exercising and their heart rate goes to over 200, obviously a concern for some type of an arrhythmia. I really encourage people not to pay a lot of attention to heart rate numbers, just because there can be a lot of noise in that data. So presumably somebody's wearing a watch or a chest strap, and they're told that way. So if there's pathology, if there's symptoms, then we take it very seriously. We do investigations. If there's concerns about decreasing performance, increasing fatigue, again, then that heart rate sort of is just a piece of data that we roll in. But in a vacuum, heart rate numbers can be very noisy, very challenging, and we discourage people from paying as much attention to them and more on how they feel than the actual numbers.
Kathleen is wondering, if you had any athletes who survived COVID, what are some of the after effects you have seen? Is there a difference with the age group of these athletes?
Wonderful question. We've seen, fortunately, knock on wood or whatever substance you want, Tons of athletes with COVID at this point in time. We've seen professional, we've seen Olympic athletes, we've seen all the way through into just recreational exercise. Fortunately, we have not had a bad outcome in an athlete yet. So most are doing well. Most return to their sport after their isolation period and their gradual return to play. We've emphasized a gradual return to activity, not immediately, hitting the bike, hitting the weight room, exercising as they were before their infection. But what we are starting to see a lot of, this goes back a couple of months, is significant deconditioning in our athletes. So really getting knocked back to square one. And this shouldn't come as a surprise to us. There is good data out there that shows that viral illnesses, or any illness for that matter, can really negatively impact an athlete and can set them back. So we're going through the testing. We're making sure it's not a cardiopulmonary issue. We're making sure that everything is sound. But then we're having really long and detailed discussions with the athlete for them to be humble. The mind hasn't changed. The mind still thinks that they can run their 6-minute mile, that they can go out for their 100-mile cycle ride. But the body just has been knocked back significantly. Cardiopulmonary testing is exquisitely important here because we can set baselines and then use it to help us see how the athlete is doing. But it's a lot of counseling on our part to get them back to the performance levels that they wanted. Again, COVID's been an equal opportunity employer in this. Our professional athletes and weekend warriors alike are suffering the same consequences.
Mm-hmm. And talking about weekend warriors and sedentary lifestyle, Gabrielle is wondering, how can people with sedentary lifestyle start exercising while minimizing the risk of myocardial infarction?
Yeah, so for most people, just start. Start slowly. Don't think that you're going to go from 0 to a marathon overnight. Really take your time, slowly engage in the exercise. If you've never exercised before, just walking 5 minutes per day is a really good start, and you'll get health benefits of that. As you sort of go from there, increase, see how the body's doing. If you have any symptoms at all, or if an athlete has any symptoms at all, or non-athlete, chest pain, abnormal shortness of breath, passing out, palpitation, it's really important that person gets testing and follow-up to see if anything's going on. But really, unless they have high-risk conditions or high-risk history, I don't think a screening test is warranted. Just engage counseling on the front end with the physician or the healthcare provider to discuss an exercise plan is probably the safest way to go.
Samuel is wondering, does the ACE inhibitor maintain the normal size of a cardiovascular muscle?
So not sure if that's in association with somebody who has established cardiovascular disease or somebody who we're treating with hypertension. So ACE inhibitors, ARB, act in the angiotensin pathway. Those biochemicals can impact the heart with what we call cardiac remodeling. It can cause scar, fibrosis, left ventricular hypertrophy, et cetera. So in somebody, let's say, who's had a heart attack, who has a cardiomyopathy, yes, those ACE inhibitors, ARBs, are meant to help strengthen the heart, get it better, prevent sort of the adverse remodeling that takes place from the biochemical, biohormonal systems that after an insult to the cardiovascular system. In general, though, an ACE inhibitor or an ARB won't impact necessarily the cardiovascular system for someone who's otherwise healthy. The reason why they're on the watch list is because they may augment sympathetic tone, which obviously would have performance enhancing capabilities.
Have any of your athletes who survived COVID turn out to be long haulers?
Yes, so I think that goes back to the question just answered. Yes, there are those who have become significantly deconditioned and set back, and again, true of the general population as well. And I sort of don't like the term long hauler necessarily. I think it's an established post-viral syndrome that I've known about for a long time with other viral illnesses. It's just so many people are getting COVID. It's highly contagious, terrible disease. That we're seeing a lot of high volume people just having post-viral syndrome now. So again, it's a lot of time with us talking, sort of setting expectations. And again, the hardest thing for an athlete to have is humility, and that the mind's telling them one thing, but the body's just not ready for it yet.
We have a great athlete in Ana Basil, and she is wondering, are there any supplements that should not be taken by athletes?
So that is a very individualized discussion. I think if an athlete's competing and doing so at a competitive level, where urine and drug tests may be involved, you have to be careful, because my favorite adage with supplements, which is stolen from a sports nutritionist, is that what you think goes into a supplement may not be there, but what you don't think goes into a supplement may be there. So you have to be very careful. a lot of athletes will engage with vitamin D, fish oil, citrulline, arginine. The list sort of goes on and on. Again, very individualized discussion about why the athlete's engaging with the supplements, what he or she hopes to achieve at the end of it, and we sort of can help counsel in that regard. Blanket recommendation: most people who in the United States and other developed countries who eat a well-rounded diet do not need supplements, vitamins, and minerals. Everything you need goes into the foods. The only pre-workout supplement you may need, glass of orange juice or a cup of coffee. All of this pre-workout and those things, these companies are going to come after me because I don't like them. They cause increased burden of arrhythmias and sudden death. And then all you need after a workout is a banana and a chocolate milk. All these other things that are marketed out there are fine, but chocolate milk is all you need.
It is what it is, and the truth must be said.
Yeah.
Whoever gets hurt, then fine.
Yep.
Now, Dr. Friedman, we definitely have come a long way in medicine, and we have talked ad nauseum about preventing disease and making certain that our population is cared for, and at least they take advantage of physical participation in activities. And also, we push our patients to actually go and do their yearly checkup. What we see oftentimes is that the checkup is not necessarily or does not necessarily encompass a good cardiological type checkup. Okay, it is perhaps an EKG, blood pressure, and only if the physician finds something, then they will route them to the appropriate specialist. My question is, are there any talks in regards to switching the mind frame in regards to how to treat the well patient, or for primary care physicians to include a cardiological type examination that will take into account those incredible tests that you mentioned, that they're readily available, including the calcium scoring? Um, i- is there any change in this? Are there conversations about this?
Yeah, so we see a lot of athletes who come in for exactly that reason. They just want a cardiac checkup to make sure that everything is well. And a lot of times, unfortunately, it happens because there's been an event in their training group, whether it be their running group, their triathlon group, their cycling group, where somebody either has a heart attack, somebody develops an arrhythmia, or even worse, somebody dies, and they want to make sure that they're healthy and safe to continue to do so. So, we really relish those conversations. We spend a lot of time talking about all of those features that don't just deal with acute care. So yes, we ask about symptoms, but we also just want to know how the athlete's doing. What are they doing? How are they fueling their body? What are they eating? What are they drinking? How are they sleeping? We look at blood work. We look at an ECG. We want to know their family history. Is there any high risk features? My favorite saying to tell an athlete is you can't run from your genes. That exercise is not immune therapy. No matter how many miles you log, how well you eat, if your genetics aren't so great, then you may have to face that at one point in time. So yes, the answer to your question is we do not spend enough time in our country on preventative care and counseling. We do attempt to do that in our sports cardiology clinic.
Well, we're happy that at least you guys are doing this. Doctor, we're at the top of the hour. We need to be considerate to you. I know it has been a long day for you. And I want to make sure I thank you on behalf of our international team. We're really thrilled to have you, and thank you so much for accepting our invitation. And to all of you for participating, for the great questions. If you have any additional questions for Dr. Friedman, please send them to international@baptisthealth.net. We'll make sure to forward those questions to him, and we'll get back to you. We look forward to seeing you at our next Cardiac and Vascular Institute lecture series, which is scheduled for May 5th, 2021. In the meantime, thank you again. Please stay safe, wear a mask, get vaccinated when you are able to, and we'll see you soon. Have a great afternoon. Thank you, Dr. Friedman.
Thank you so much. It was a privilege.